Good afternoon. Welcome to the 2019-2020 edition of Medical Grand Rounds. It's happy to kick our session off today with a very interesting and I think exciting topic. And Wendy Armstrong is going to do the introduction. So thank you, Wendy.
All right, well, it's hard to think of a more timely topic than climate change. I originally asked these three very distinguished individuals who I will introduce to you to do this last Grand Round season. And it turned out the day that we set was the fake snow day, the one that had sunny skies and no snow, but because schools and everything were canceled and people had to be home with kids, it didn't work out. But I think actually that might have been okay because I think this is a great topic to be our beginning introductory Grand Rounds for the year to kick off the year. And in the ensuing 5 months or so, this has only become, I think, a more pressing issue, as I fear will continue to happen for many years to come. So we do have three incredibly distinguished speakers, all of whom are Emory folks that you may or may not be aware. We have actually such a wonderful group. The three of them will speak in the order that you see. So I'm going to introduce all of them in the order that you see. So Daniel Rochberg is Chief Strategy Officer of Emory University's Climate at Emory Initiative. He's an instructor in Emory's Departments of Environmental Health and Environmental Sciences and a co-founder of the Georgia Climate Project. He did, however, spend 17 years with the U.S. Department of State, where he served as special assistant to the lead U.S. climate negotiators under Presidents both Bush and Obama, and was a member of U.S. delegations to multiple UN conferences, including the 2002 World Summit on Sustainable Development in Johannesburg and the 2009 UN Climate Conference in Copenhagen. He helped shape the President's Global Climate Change Initiative and the U.S.-India Partnership to Advance Clean Energy. He was a term member of the Council on Foreign Relations and has received the State Department's Superior and Meritorious Honor Awards. Dr. Stefanie Sarnat is an Associate Professor of Environmental Health at Rollins. She holds a Master of Science degree from the University of British Columbia and a doctorate from the Harvard School of Public Health. Her research focuses on examining health effects of ambient air quality using population and panel-based approaches. She leads several large-scale time series studies of ambient air quality and acute morbidity, focusing on assessment of health-relevant ambient air pollution mixtures and metrics of extreme heat, and assessing exposure and population factors that may modify health risk. Dr. Sarnat's a member of the Health Effects Institute Energy Research Committee. And last but not least, Dr. Rebecca Philipsborn is an assistant professor of pediatrics. She's a clinical consultant for the CHAMPS program of the Emory Global Health Institute. Her scholarly work focuses on global child health and mortality and climate change, in practice and in residency education. She's published on climate and child health, including a forthcoming chapter in the World Climate Encyclopedia, and has served as a subject matter expert for the UN, for the Global Climate Action Summit, and other international groups. She's currently piloting a curriculum on climate change and health for pediatric global health track residents. She is homegrown, completing medical school and residency training here at Emory, and also holds an MPA in environmental science and policy from Columbia's Earth Institute program. So without further ado, I will turn the mic over to Daniel Rochberg.
Great. Thank you for the introductions, and thank you all for being here, both here and on satellite sites. Really appreciate the opportunity to speak with you today about climate change. As Wendy mentioned, we're going to take this from sort of big picture. It's where I'm going to start. Maybe 80,000 foot down to 30,000 feet over to Dr. Sarnat, and then down to the clinical context, which will be Dr. Philipsborn. And learning objectives track that. We hope that by the end of this, you'll be able to better explain in your own words what this issue is and why it matters, to understand the populations that are most at risk, to understand how this impacts individual health, and then to drill down to the clinical setting and how you practice, teach, and talk about medicine. I'm going to start with my kind of elevator pitch on climate change in 5 sentences, with the caveat I'm going to take several paragraphs to get to 5 sentences, but bear with me, by the end we'll have a 5-sentence summary of climate change. And I'm going to go through this pretty quickly too, because I really want you to hear from the other two, and then hopefully we'll have a chance for Q&A. First sentence and first point, it is unfortunately no longer hyperbolic to say that climate change is one of the century's greatest challenges. And it's not just me saying that, of course, it's the Director General of the World Health Organization in 2015. It's leaders across the world, both globally and locally. And I want to talk a little bit just about the basics of climate change and why it is this big issue. Many of you, I assume, come into this room knowing a lot of this, but still a refresher is always helpful, always has been for me. Here's our beautiful planet. What we're worried about is this thin skin of atmosphere we have, the tippy top of our planet. It's kind of the equivalent of a bit of saran wrap outside of a basketball. You can think about that in terms of those scales. We have a bunch of gases, as you all know, in the atmosphere. Some of them are really good at trapping the Earth's heat as it radiates out to the atmosphere and catching it, serving like a greenhouse, right? Or like a parked car. As you all know, a parked car is a lot warmer inside than the ambient temperature outside, and that's because of this greenhouse effect. For millennia, this greenhouse effect has been a really good thing for all of us and for everything living on this planet. Prior to the Industrial Revolution, we had enough greenhouse gases in the atmosphere for the temperature to be about 60 degrees Fahrenheit warmer than it otherwise would have been. So think about the alternative. Not good for civilization and species, right? So having a greenhouse effect is a good thing. The problem comes when we start to pump more greenhouse gases, especially carbon dioxide, into that very thin skin of atmosphere. That's when things get out of balance, and that's when we start to get very concerned. And unfortunately, that's exactly what's happening now. The blue squiggly line bouncing up and down is 800,000 years of data of atmospheric concentrations of carbon dioxide, which is the principal greenhouse gas. Up and down, varying over time, but you see it never exceeds about 280 parts per million over this 800,000 year stretch. This blue line is where we are now. Yesterday's concentration at Mauna Loa in Hawaii was 409 parts per million. So the two takeaways from this is, number one, we are well outside of what has been normal variability over the past 800,000 years in terms of how much carbon pollution is in that atmosphere. And number two, geologically speaking, we've done that in quicker than a blink of an eye. So we're not only changing the system and pushing it beyond where it's ever been pushed, but we're pushing it really fast. And we're seeing the impacts of that. Has anybody here seen this picture? Besides my colleagues here. It's a pretty picture. It's also an infographic, and it's a sobering one. This is global average temperatures from 1850 on the left to 2017 on the right. Each stripe is a year, and the blue stripes are colder than the average over that period, and the warm stripes are warmer than the average. As you can see, there's a very striking trend as you move to the right of this plot. If you were to add in last year's data, 2018, we've now had 18 of the 19 warmest years on record since 2000. And we're causing it. That's the other really important point. The consensus finding now of the UN science community, the Intergovernmental Panel on Climate Change, they're up to 95 to 100% likelihood that not only are humans causing this trend, but that we are the dominant cause of this trend. So why should we worry about it? Why should our kids worry about it? I've been working on climate change since 1997 now. It's a complicated issue. It confuses me, to be honest. It's kind of complex, and it's big picture, and it's abstract, and sometimes we're talking about the distant future. We're increasingly talking about the here and now. The way I boiled it down in my brain is 3 W's. The world is getting warmer. That, in turn, is making the climate system and the weather system weirder, which is not a technical term, but as you'll see, it works for this purpose. And you take those two together, a warming world and a weirder world, that's fundamentally worse on balance. There might be some very small bright lights, but mostly on balance, it's worse for us and the systems on which we depend. I'm going to unpack these very quickly on each of these three. Here's warmer. Obviously, extreme heat has a direct impact on infrastructure. This is the roads of New Delhi in 2015 physically melting during a heat event, and also on human health. More than 2,000 people, unfortunately, died in this particular heat wave. Tens of thousands died in a European heat wave in the early 2000s. We've had excessive death tolls in the US as well, especially in Chicago in the 1990s. If we look at the US and project out to the future, I want to look at the number of days projected above 100 degrees. This is the past. This is the last part of the last century. The yellow that you see in Georgia is less than 10 days a year above 100 degrees Fahrenheit. I'm now going to show you what the future looks like in a scenario where we don't reduce our emissions. We just sort of stay on business as usual. As you can see, it's a much different paradigm for extreme heat across the United States. Here in Georgia, we're looking at going from 10 or fewer days a year. Remember, last week's heat wave, as bad as it was, I'm not sure we actually topped 100 on any one of those days. We might have done it on one of the days. We're talking now about 30, 40, 50, sometimes 60 days a year above 100 degrees. And I know this says 2080 and 2099. I want to bring it back to future generations. If Lucas, my kid, is lucky enough to live as long as I hope he does, he'll be 66 in 2080. He'll be 85 in 2099. So climate change is already happening now. That's the stripes I showed you. It's going to get worse. So it's an issue for our generation. It's an issue for our kids' generation, and very much for their kids' generation. The second thing is weirder. One of the things that happens in a warmer world, of course, is that ice melts and water expands and sea levels go up. The Georgia coast is already 9 inches higher sea level than it was 100 years ago. This is the only road that connects the mainland of Georgia to Tybee Island. This is Highway 80. This is during a sunny day flood. This happens now more often than it ever used to, and several times a year, where we get sunny day flooding overwhelming some of our infrastructure. It's bad enough if you're in Georgia. It's much worse if you're in the Maldives. This is an aerial photo of the Maldives. It's a sovereign nation of 300,000 people, average elevation above sea level 1 meter. If you project out to the future, you look at the UN's projections, anywhere from 1/4 to 4/5 of a meter of sea level rise is what we're looking at in the next century, which is an existential threat to this country and to several others. The other thing that happens in a weirder world, not only does sea level rise, but our hydrometeorological system gets different. We see especially a lot more extreme weather events. We're also paradoxically going to see a lot more drought. But on the extreme rainfall side, the rainfall that we're seeing and going to see is overwhelming communities' capacity to get that water out of there. So it leads to all sorts of infrastructure, health, and other economic impacts. And then finally, today's news, of course, this is not Dorian, although Dorian looks almost this bad. This is Isabel from several years ago. I pulled up something actually this morning from AAAS's sort of summary of how do you think about climate change and hurricanes. The bottom line here is scientists don't yet know whether hurricanes will become more frequent than they were before, but they do know that they're quite likely to be more intense now and be even more intense in the future. And moreover, those storm surges are on top of an elevated sea level. So you got sort of have a double punch. And that's what we're seeing now. Finally, the worst part. So if you take those together, they start to impact, warmer and weirder impact systems that we care about. Food security, water availability, all the ecosystems on which we depend and that have intrinsic value, and of course, public health. And I'm going to defer to my colleagues to really unpack this, but a number of linkages here. And those, in turn, if you take the cumulative effect of that, it's a big economic hit. This is projected impacts in the US, the end of the century, county by county, red is bad. And you see the Southeast is uniquely vulnerable to the impacts of climate change from an economic perspective. And then national security. This is from the US Department of Defense, whose first job is not to think about trees and to think about the environment, but to think about bedrock national security issues, saying that the impacts we're likely to see are going to be threat multipliers and make us more concerned about everything else we're worrying about. That was one sentence. I promise the other ones will be a lot faster. Okay, so climate change is one of the century's greatest challenges. What do we do about it? We've decided as a global community, in a process I won't get into in the Paris climate negotiations, we're going to try to keep temperatures from increasing to 2 degrees Celsius above where they were before, about 3.5 Fahrenheit. Ideally, we're going to cap it at 1.5 Celsius. To put that in perspective, we're already a degree up now. So there's not much wiggle room between where we are now and 1.5 or 2. To do that, that means we have to reduce the amount of pollution going into that thin skin of the atmosphere I talked about earlier. This is one plot of that I used to show a year ago. Here's where our emissions are about to go. It's measured in billions of tons. You don't even need to worry about the axes right now, except for the x-axis. This is where our emissions need to be by the end of the century to be on the 1.5 degree pathway. And even from the back of the room, you can probably see that the green line crosses the x-axis. In other words, net zero emissions on the planet. At that point, 10 or 11 billion people on net having zero carbon emissions by the end of the century. That was the slide I used to show a year ago. And then more science came out from the UN where they updated their assessment of how much time we have. These are the headlines from Fox News and the Wall Street Journal. They capture the point. The shorthand version of this is basically the deadline shifted up. So now the 1.5 degree pathway, our deadline is 2050 to be at 0 in order to have a good chance of avoiding a 1.5 degree future. If we want to take the more relaxed target of 2 degrees, we have until 2070, which is really soon to do a whole lot of work. So point number 3, we have to have a net zero emissions planet well before now the end of the century. Point number 4, how do we do that? The cop-out answer, especially in the time we have, is we have to do a lot of things at a lot of scales. Principal amongst those, we have to change how we produce and consume electricity, starting here at Emory and all the way up to what we're doing in the United States and in other countries. Number 2, we have to change and transform how we move people and products from one place to another. And number 3, we have to think much differently about how we're managing our land resources, especially our forests and our agriculture. And in terms of the scale to act, if you think about a Google Maps slider, there's no silver bullet there either. We have to take global action, things like the Paris Agreement. We also have to take individual action and everything in the middle, organizational, city, state, et cetera. And finally, my 5th point is even when we do that, to be optimistic, let's say when we do all this heavy lifting, there's a lot of impacts happening now, and they're baked into the system, and they're going to be for decades to come. Even if emissions went to 0 today, we're not out of the woods. So if you think about a global thermometer, up here is this concept in climate land of mitigation, of avoiding the unmanageable. But we've already baked enough. Let's say we go to 2 degrees. We have to deal with everything up to 2 degrees. So we have to manage what is unavoidable. And I actually think that's an incredibly important role for the public health community and the clinical community to be thinking about, is there are impacts that we cannot avoid that we need to figure out how we respond to, how we adapt to, and how we build resilience to. Okay, so that was climate change in 5 sentences. Before I turn it over, as a segue, I want to just briefly give you a very brief overview of some of the work we're doing here at Emory on this, for those of you who don't know about it, in case you're interested in getting involved. The first thing is Climate at Emory is our effort to pull together faculty, staff, and students on campus and abroad, parts of the Emory community, who care about climate change into a shared community. We have about 70-ish faculty and staff now, over 100 students across 20 departments. The basic idea is the things that any university does well. We teach, we conduct research, we engage in our community. In your case, you're engaging clinically. If we can train those resources and talents onto climate change, we can have an impact. And really every university and college around the world needs to be doing this to step up its game. I won't unpack this too much, but just a couple examples. We have a great student group that's been kind of a think tank working on climate issues. We have a bunch of journal articles emerging from different parts of the campus. We have Becca's is there, and we've got environmental sciences, anthropology, the business school, School of Public Health. And then we're trying as much as possible to walk the talk here at home. So we have great work being done by the Office of Sustainability to make sure that we're leading by example. We're also working with City of Atlanta. We're doing this thing called the Georgia Climate Project, which I'll spend 2 seconds on shortly. And then we're now sending students every year to the UN climate talks as well. If you want to get involved, I didn't put it up here, but it's climate.emory.edu. Twitter, it's @climate@Emory. Probably if you Google climate at Emory, you'll get to those sites. And feel free to sign up, get involved, or reach out. And then the last thing I want to mention is this thing called the Georgia Climate Project, which is basically our effort to build capacity within the state of Georgia on climate change, recognizing that sooner and later, we're going to have leaders across the state who want to move forward on this issue, and they want to know who to talk to and who can work alongside them. We started with Emory, UGA, and Georgia Tech. We've broadened out to 7 schools now, and we're working with a much wider range of partners across the state on this project. And then basically what we're trying to sort through is, what does this mean for us here in Georgia, number one, and then what do we do about it? And the one thing to flag there that's most urgent is November 7th and 8th this year at the Emory Conference Center. There will be only the second ever statewide climate conference that we're going to be hosting here soon. With that, thank you very much. I'm going to turn it over to Dr. Sarnat, and we'll go to the population scale.
Hi, well, good afternoon, everybody. Pleasure to be here today. I'm going to kind of take from Daniel's kind of big, broad overview of climate change and impacts on health and bring it down to the level at which we often try to characterize and estimate and quantify the impacts of climate change and climate change-related exposures on health outcomes. And often I'm going to just point out that I'm not actually going to be showing any actual climate health impact projections work. I'm really basing a lot of my own work on what we experience today. So we already know that climate change is happening. We experience heat waves. We experience a lot of other climate-related exposures today. And so a lot of the work that is climate health impact projections for the future is based on associations and estimates that we see in today's world. So just a little bit of a nuts and bolts on how we do that. I'm going to draw on a long-standing study that we have here ongoing at Emory. It started out as the study of particles and health in Atlanta, which we acronymed the SOPHIA study. And we've used this study to actually look at more than just air pollution, but a lot of other climate-related exposures. So here on studying the heat health linkage, I'm showing you a map of the Atlanta study area where we take data on temperature and other meteorological conditions from monitoring stations in and around Atlanta. Here showing the weather station, or the Hartsfield International Airport, where there is a weather station located. So we acquire data from weather stations. We also have been acquiring data on kind of population-based indicators of health utilizing emergency room visit data. Our study has been ongoing since the early, or really the late 90s, but with data gathering back to 1993. So we started out with gathering data from individual hospitals, and then over time we've been lucky enough to work with the Georgia Hospital Association to acquire patient-level visit data for hospitals in our study region. And we use these data to really examine the day-to-day associations between exposures, here thinking about heat exposures, and health. Our data looks something like this. So for example, on the exposure side, we might have a really long time series from 1993 through 2012 on daily maximum temperatures. You can see the seasonal variability in those daily maximum temperatures over the 20-year period. And on the health outcome side, here I'm showing a graph for the similar time period, 1993 through 2012, on daily counts of ED visits for fluid and electrolyte imbalances, so including dehydration. With actually, I don't have the legend here, but the yellow dots are the daily counts for all ages, and the red dots are those for those 65 and older. And just as a little bit of a close-up, this is the view for the last 5 years of our study, so you can see some of the daily and seasonal variation in our data. And what we do is we run regression models, Poisson time series models, to try to estimate the association between the daily exposure values and daily health outcomes for the population. Our results look something like this. This is again for the fluid and electrolyte imbalance ED visit outcome for 3 different age groups. So each panel is kind of the results of one of our models, where we're looking at the association between daily maximum temperature and fluid and electrolyte imbalance ED visits, with the results being in the form of a rate ratio. Each dot represents the increase or decreased rate of ED visits relative to 27 degrees. So 27 degrees in the warm season is about the 25th percentile, also translates to about 81 degrees Fahrenheit. And the red dots indicate just as an example, the increased rate of ED visits for a 5-degree increase from 27 to 32 degrees. So here, those rate ratios translate to approximate percentage increases. So for example, among adults in Atlanta, among the warm season, this 5-degree increase represents about a 17% increase in the rate of ED visits. So quite a substantial increase in ED visits related to heat, which makes a lot of sense, it seems, for dehydration-related outcomes and heat exposures. And one of the take-homes here is that we see this very logical association between heat exposures and outcomes. I also want to point out that these types of associations are seen for a really broad range of outcomes, from all-cause mortality outcomes to a broad range of different morbidity indicators, including in our data set here on the ED visits, renal outcomes, so kidney-related diseases, gastrointestinal impacts on those with diabetes and hypertension, as well as impacts on respiratory outcomes. And these types of estimates, for example, the 17% increase rate, is the type of estimate that's then used in health impact projections under different scenarios for climate change in the future. What might we expect the health impacts to be? But just as an example of the broad range of outcomes that we do see associated with heat, asthma is one of them. Just going to highlight some results where we see strong associations between heat-related exposures and asthma ED visits among children. Here showing specifically that several days after the high heat event, we see a significant increase in the rate of ED visits for pediatric asthma. And it's important to note that this association is kind of the average association that we see in Atlanta, but we know that the burden is not necessarily equal among all population groups. When we, for example, stratify our analyses by different sociodemographic characteristics, we see that the risks are really similar between boys and girls, but in our data set at least, the risk is perhaps not so equal between white and non-white children. So as an example, showing that the burden of climate-related exposures is not distributed equally. And so estimates like these will help hone in on climate change health impact projections and perhaps make them more accurate. It's also important to note, I just wanted to kind of, into the next few slides, talk about the fact that it's not just logical exposures such as heat that are of importance with regards to climate change and air quality, but there's a lot of other, perhaps more indirect effects of climate change on air quality indices that are important for outcomes that are, for example, also on asthma. So asthma being quite a climate relevant outcome. Pollen being one of those exposures. We're concerned that under climate change, the flowering seasons for plants, for trees, grasses, and weeds will be altering. So both changing in terms of geographic location, but also within a certain location where we're concerned that the flowering seasons will be extended, so longer seasons, as well as more intense. So that pollen concentrations will become more intense for longer periods in the future. Here's an example of data, I think, from 2004 showing the concentrations of pollen from different species. Here, the top four are trees. This one here is grasses and then weeds, showing how there's a big seasonality for pollen concentrations depending on when those plants are flowering. And we very logically also see very strong associations between these pollen species and asthma ED visits. Here, specifically for oak pollen, we see in the days when pollen concentrations are the highest relative to those days with no concentrations of oak pollen, we see quite a staggering increased rate of ED visits for asthma. So asthma, for example, is not only impacted by heat, other air pollution metrics, but also pollen. So there's multiple exposures that are impacting some population groups. And also from the exposure side, to make things just a little bit more complex, we know that pollen themselves are impacted by perhaps other climate-related exposures. We've done some work on thunderstorms and asthma with the idea that thunderstorms may impact asthma morbidity through impacts on kind of osmotic shock of pollen grains, where the wind and heavy rains from thunderstorms will kind of cause pollen grains to burst and thereby mediating asthma morbidity. And sure enough, we do see this strong association between thunderstorms and asthma ED visits that are prevalent mostly when we have thunderstorms with wind and rain. So as quick take-homes before I leave it over to Rebecca, is that we have a multitude of exposures that we're concerned about with climate change here. My focus really is on air quality, so I'm really focusing on air quality, but there's a lot of other types of exposures, especially through water pathways and other types of pathways where we're concerned about impacts on human health. The impacts on human health are broad-ranging, as well as that there's an unequal distribution of the burden. And with that, I'll leave it to Rebecca to finish up.
Thank you, guys. So you set me up well, Stefanie and Daniel did, for what is our role? Why does this matter for doctors as we practice, teach, and talk about medicine in a changing climate? Before we were snowed out in January, when we were initially supposed to come talk, there was this great piece released in the New England Journal, January 17th, that really for the first time looked at exposure pathways in climate and health. It was going to be a great prelude to our conversation. But Dr. Armstrong is right. Even since then, there have been even stronger calls to action for physician engagement in climate change. So this came out in June 24th this year. It was released by the American Medical Association and dozens of other health organizations. Actually, Emory School of Nursing, not the School of Medicine or the School of Public Health, have signed on yet. But it's a policy action agenda stating climate change is one of the greatest threats to health America has ever faced. It is a true public health emergency. Then in June as well, the AMA released a policy statement supporting climate and health education across the spectrum from undergraduate, graduate, and continuing medical education levels so that physicians acquire a basic knowledge of the science of climate change, can describe its risks, and can counsel patients accordingly. Then again, just a couple weeks ago, August 22nd, the New England Journal featured no less than 6 pieces on climate and health, and they're launching this as a topic area on their website. Well, they'll have updates for climate and health resources for physicians. This piece is an interactive feature that shows how climate change really impacts every organ system and almost every aspect of the practice of medicine from healthcare delivery standpoint. The bottom line for why this is such a big deal is that climate change harms our patients. The things that we're seeing, increasing temperature, Changing patterns of rainfall, intensifying natural disasters, and sea level rise create exposure pathways that directly threaten the health of our patients. And perhaps the most profound impact comes from heat itself, which Stefanie just delineated. With rising temperatures, sweating becomes a less effective mechanism for cooling off so that patients are at risk for hyperthermia and dehydration. It also increases blood viscosity and cardiac workload so that we see a higher incidence of chronic kidney disease. This is a feature in the New England Journal, this heat-related nephropathy, cerebrovascular disease, and cardiovascular disease. There's an inflammatory effect from poor air quality and air pollution, which Stefanie also mentioned, which can also lead to respiratory illness. So air pollution is worsened by heat and actually has an emphysematous effect on lungs. For children, this effect is profound and can have a lifelong consequence on total lung capacity that persists into adulthood. It's worth noting that about 92% of the world's population currently lives in areas with unsafe levels of air pollution per WHO standards. Stefanie talked about pollen as well. The increased carbon dioxide increases the amount of pollen that plants produce and prolongs the pollen. It's not just our patients' imagination that their allergies are worse now than they used to be. Climate change will increase the incidence of common food, water, and vector-borne infections and increase the range of some vector-borne infectious illnesses. These two, drought and flooding, are these extremes of the hydrologic cycle, where some places will become drier at risk for drought and fire, and other places will become wetter at risk for flooding. Both of these mediate food insecurity, water scarcity, and malnutrition. Flooding is a risk itself for injury and for drowning and causes exposures to toxic substances through algal blooms or through release of chemicals that we saw after Hurricane Harvey when chemical plants spilled toxic substances into the surrounding area, or through Hurricane Floyd, there was these breach of coal ash pits that spilled into the Cape Fear and surrounding waterways of the community. And displacement itself is perhaps the biggest lever on mental health outcomes for our patients, where they see their life as they know it just completely upended because of a natural disaster. Now, all of these exposure pathways could be a lecture in their own right, so I'm going to focus instead on some takeaway principles for you all in your practice of medicine. We're going to have to change our index of suspicion for the coming years for what we will see. The diseases we treat will change because of climate change. So this map shows the projected change of Aedes aegypti, the vector for dengue, chikungunya, yellow fever, with the current range in blue and the range in 2050 in orange. You can see the Southeast United States is one of the areas where Aedes aegypti will expand its range. This makes sense. We know that increased temperature, both including increased daytime temperature, warmer nighttime temperatures, less daily variation, and longer warm seasons affect mosquito behavior for flying, fighting and feeding, and even reproduction. Flooding causes more standing water and increases suitable habitat for this vector. And this is just one example of the vector-borne, the vectors that will change their range due to climate change. Another big principle is that we are all exposed. The climate is a shared resource. When the exposure is ubiquitous, like heat, and the baseline burden of disease is already immense, even a small % increase represents a large amount of illness. So in Atlanta, by 2050, we're expected to have about 90 extreme heat days per year. That's compared to 20 per year now. So when I talk to pediatricians, because I am a pediatrician, I tend to focus on infant morbidity and mortality, that maternal and child health dyad. But think about the diseases you treat that are climate sensitive: stroke, heart disease, chronic kidney disease, asthma. There is already a huge burden of illness, so that the incremental increase from climate change represents a huge burden of preventable illness going forward. And finally, children in the poor and low-income countries and low-income communities of color are disproportionately harmed. So take asthma again as an example. In children in the United States, the rate of asthma is about 1 in 10. In African-American children, it's about 1 in 8. In inner city communities and urban areas, it can be as high as 1 in 4. And yet, these communities are often those who have contributed the least to this problem. There's a huge social and intergenerational injustice component here. And that principle about environmental determinants of health that are worse in low-income communities, think about mold and mildew, think about ability of a community, the combined resources to buffer against a natural disaster, to rebuild in the aftermath of a disaster. That's repeated for several environmental exposures. As physicians, we have a role in assessing our patients' risks and resources so we can better counsel them. We need to think about their exposure risk. How likely are they to be exposed to climate threats? And then their physiologic vulnerability. What are their physiologic and psychologic factors that make them more at risk of serious impact if they are exposed? So all children are more vulnerable because they're still developing. They're dependent on their caregivers. But there are so many categories of patients for whom this is true. How many patients do you have who are dependent on caregivers, who need a daily dose of medication to stay alive, who need dialysis? What would happen to them if these support systems were disrupted? We have a role in counseling them. It's not just because they trust us. Sometimes we do things to them that actually increase their risk, like all of these medications which have mechanisms of action that blunt the body's natural thermoregulatory response and make patients more at risk for heat-related illness. Or we prescribe medications like insulin, thyroid medicines, albuterol, and epinephrine, which actually have altered pharmacology above room temperature. If you read the labels on the medicines you prescribe, room temperature allows for excursions up to 86 degrees, but not beyond. Albuterol actually, in addition to delivering less of a dose over room temperature, has on its label that it is at risk of exploding in temperatures above 120 degrees. Now, we're not talking about ambient temperatures above 120 degrees, but if you think about your car temperature on the top of the Grady parking deck in the summer, it's definitely 120 degrees when you come back after a long day at work. So we need to be counseling our patients where to store their medicines, not to store them in cars. This is a conversation I have now with my high school athletes when they're getting their sports physicals done. Climate change also alters the effectiveness of our drugs. One of these maps is minimum daily temperature, and one is antibiotic resistance for E. coli. So these authors found that a 10 degrees Celsius increase in minimum temperature across geographic areas was associated with increased resistance for E. coli, Klebsiella, and Staph aureus. The effect was still significant when they controlled for prescription rates, population density, and laboratory standards. It was a big study. It's just correlation, it's not causation, but they did propose biologic mechanisms. We know that temperature influences bacterial replication rates. We know that it influences gene transfer. And they postulated it could also influence more complex human, environment, animal interactions, that One Health approach that could lead to transmission of resistant strains between species. Climate-related weather events disrupt the tools we have at our disposal. We saw this very well in Hurricane Maria when several pharmaceutical companies had their production facilities in Puerto Rico. They were incapacitated by the storm for many, many months, and the US FDA monitored 90 medical products for shortages, including 40 drugs. In the pediatric world, this changed the protocol we use for neonatal sepsis. In other areas, we had shortages of IV fluids so that we were actually having to ration. There was a piece in the New England Journal then on hospital-based oral rehydration strategies to overcome the shortage of IV fluids. Or it can threaten our facilities themselves. This is just the eeriest picture to me. This is Manhattan. This is NYU Hospital in 2012 in Hurricane Sandy. No lights, no power, no electronic medical records, filled with patients who needed to be evacuated. Imagine the logistics of getting patients down the stairs safely in the dark, much less safely received at another facility. What if this were Grady? How prepared would we be for this kind of evacuation scenario? And what is our role in training our residents and fellows who are going to practice all over the country and may see disaster scenarios from climate-related events? Or as a regional hub, we may have to absorb climate migrants, care for them when they're displaced. This is just a Google map track during Hurricane Irma. 7 million people for evacuation in Florida. You can see pretty clearly from the map where they came. I definitely took care of some of these children during that time. Or we may have to absorb climate migrants from longer-term regional climate scenarios. So these two maps show projected sea level rise in Florida at the end of the century under unchecked pollution and extreme carbon cuts. Now, the scenario with extreme carbon cuts doesn't look so terribly bad until you realize that the blue area along the coast is where most of the population lives. Where will these people go? As an international hub in Atlanta, we will see spillover effects from global natural disasters as well. We're actually already seeing this. A lot of the Central American migrants that we're caring for are coming because of drought and lack of agricultural production in their home countries. In fact, since 2008, 24 million people per year have been displaced due to natural disasters, and these are climate related. Who will care for them? The scope of these impacts becomes really big, like Daniel said. It overwhelms me as well, and it can become hard to conceptualize. I think that physicians have an important and a strong and as of yet underrepresented voice in talking about climate and health to patients, to the community, to our places of practice. These are the words that were in the August 22nd issue of the New England Journal. I just pulled them directly from the journal and how they are talking about climate change. And perhaps this quotation says it best. As stewards of community health, we take the pulse of humanity daily and see the casualties of climate change firsthand. We believe that physicians have the opportunity to change the course of the future. So while we need to talk about climate change frequently with strong words, we also need to give our patients that message of hope and empower them. It turns out that we're in a good place. They actually trust their primary care doctors. While they don't trust me on vaccines anymore, they still trust me on climate change. And more than they trust the EPA, the WHO, the health system, the weather. So we have an opportunity, really a medical imperative, to educate through our anticipatory guidance, to prepare patients for the risks that they are going to face. And there are lots of tools out there now to help us. There's heat action plans, there's disaster preparedness plans. We need to be conversations where we recognize the link to climate and make the connection with our patients. We also have an obligation to prepare our trainees, and in a lot of cases, the demand for climate and health education is coming from students themselves. So Ben and Emmeline sitting in the back are starting a process to get climate integrated into the medical education curriculum at the undergraduate level here at Emory. This is just a shot of a framework that I use for my global health residents. And I recently submitted with colleagues across the country a pediatric climate health curriculum linked to the ACG Immune Core competencies for residents as well. So here at Emory, I think I'm for a partner in crime on the internal medicine side. If anyone's interested, let me know. We also have a role in advocating. The healthcare sector contributes 10% to total US greenhouse gas emissions. What can we do with our mandate first, do no harm? What is our role in reducing those emissions here in our places of practice? A lot of the things that we need to do when we take stock of our own food, transportation, energy, sources, and choices, a lot of the things we need to do have benefits for us anyway. It's called health co-benefits of mitigation actions. So eating less red meat. Red meat contributes 30% of the emissions from the agriculture sector. So a more plant-based diet is healthier for us anyway. Cleaner energy results in less air pollution. Transportation options that rely less on single occupancy vehicles, it's more physically fit. And of course, we can vote. So in conclusion, climate change is happening. It has profound implications for humanity and human health. Children and the poor are more vulnerable. You will see health and health systems consequences of climate change in your practice. These will require adapting your practice and adaptations in our healthcare sector. And you have a way. There are bunches of resources out there. These are just some of the websites that have become available, and these are updating their content all the time now. We're in the process of starting a medical society consortium on climate and health chapter here in Georgia. There will be one soon. The next kind of startup call is Friday. Again, if anyone's interested in being a part of that, please let me know. Right now, we don't have a chapter in Georgia, even though several states do. We have a great sustainability program here at Emory. I'll give a shout out to them as well. And they're another place for great resources. And then here's some additional references and further reading. I think with that, should get the other two up here and we'll open it up for questions.
That was outstanding presentation and a really critical issue. I'll start it off by asking about the greenhouse gases. I've heard that methane may be a more powerful greenhouse gas than CO2. Can you comment on that? And my general question actually has to do with research and who's funding research in this area, and what are the opportunities to get engaged on the research side. So a specific question about greenhouse gases and their contribution, what can we do about them, and then the research question.
I'm going to take the first. You guys can say. Okay. All right, great. So question one about the greenhouse gases. Carbon dioxide is most often talked about. It is the principal contributor to net greenhouse gas emissions, but there is a basket of greenhouse gases we worry about. Methane is certainly one of them, pound for pound and part per million per part per million. It's much more potent, much better at trapping the Earth's radiation. Turns out one of the more non-intuitive ones, somebody recently ranked the top 100 things we can do to solve global warming. It's a project called Drawdown. You should definitely check it out. Number one was, it turns out, not wind, not solar, not methane. It was refrigerant management, because HFCs, hydrofluorocarbons, which were a great substitute for CFCs, which were depleting our ozone layer, turns out are incredibly potent greenhouse gases. And we have enough of those right now in our cooling devices around the world, especially in emerging economies, that if we can phase out of those, with up to 0.5 degrees Celsius warming simply by making progress there. So unfortunately, for all things climate, there's this sort of all of the above approach. Methane is a big piece of it. It's not the silver bullet, but neither is carbon dioxide, and neither are HFCs. So I'm going to the research question.
Okay, so I guess I'll take the research question, research funding question. In general, funding's on short supply. So there's not a lot of funding out there. And on the health side, climate and health is priority within the National Institutes of Health, especially National Institutes for Environmental Health Sciences, NIEHS, funds some climate and health work. There is also some funding, I guess, that some colleagues have gotten through either the National Science Foundation or NASA for doing, for example, air quality work that's related to climate. But in general, some researchers are having luck with more foundations type of funding as opposed to federal funding. But in general, funding is on short supply. So there's no huge funding streams from any given source for climate change. That's mine. But feel free to add.
Just a bit there. I think we're a little bit behind as practitioners in translating the work of our environmental science and public health colleagues into clinical medicine. And I think we have a role there, ways to add a climate platform to existing research platform for things like antibiotic resistance. And we really have to kind of show the value of that. I think if we do, perhaps more funding would become available. But I would challenge people who are doing research to think about, is there a climate and health component? Because so much of the information that can feed into it, these climate and weather variables are available from sources like NOAA, and perhaps there's a way we can add some studies on.
Questions from the audience?
So I appreciate your call for physician advocacy. I'm a huge believer that physicians' voices aren't loud enough often and can have an outsized impact. I think, like, at least speaking for myself, it feels like we are at a time with an administration that is so resistant to thinking about climate change. Like, are there messages, or are there, it feels like, the ACP or others sort of piling on may not have an effect with this current administration. Are there avenues, or are there messages, or are there other ways where physicians can make an impact that you think might have more legs?
I think recently the strategy has just been to take it completely out of the realm of politics. And it's true. So I don't talk about politics when I talk to my patients about their allergies or about their child's asthma being worse. But I do talk about air pollution and heat and the effects of climate change. I have those discussions in clinic. I think we're in a unique position partly because we have so many opportunities. So much interface with other people's lives. We talk to so many people daily. We have a chance to educate And as more and more people are becoming educated, there is that realization that this needs to happen. Health entities are starting to take action themselves. So Kaiser, Gunderson Health in the Midwest, these are organizations that have made commitments to switch away from, to become carbon neutral themselves. And I think more and more entities will have that, will follow suit. So our role can be to advocate even to our own places of practice that has an impact and has had an impact.
Question in the back? No? Yes? Okay, okay, thank you. John, any questions from, all right, great. Well, we very much thank you for your time and really discussing this really important topic. Thank you very much.